All right. So we're just gonna continue on with the antiarrhythmic note. That's section 6 and subsection 2. We were talking about ranolazine, and I want to before going on to some cases, I want to mention something about ranolazine. I was stressing that it has a propensity to cause torsade de pointes. Remember that ranolazine is a delayed sodium channel blocker, and what that does is it affects the phase 1 of the phase 0, not 1, the upslope, the phase 0, the depolarization, right? That's the first slope, phase 0, and what that does is it potentially prolongs the QRS, and then that can precipitate a prolonged QT because the QT actually involves the QRS within. So that's one thing to consider. But overall, it actually has an antiarrhythmic drug in people who have angina. And there are multiple studies that have showed that it's really good in that regards in preventing sustained VT and that sort. And so you have to know both these facts. That it's a good antiarrhythmic. It has very little proarrhythmic medications until you combine it with a medication that prolongs the QT, then ranolazine becomes at high risk of torsade de pointes. I thought that's an interesting caveat. So let's take scenario 1. You will be consulted by the psychiatrist, review patient's drugs for any of the following that would cause QT. So they see a QT that's like a 480, 470, and the ECG paper will tell them that that's long, and it's just auto-generated by the machine, and they'll call you. They'll be anyone on any one of the following, that's the patient, any one of the following medications. So these are the things to look for. We look for fluoxetine, quetiapine, amitriptyline, haloperidol, sumatriptan, ziparazidone, and risperidone, and imipramine, as well as doxepin. So these are very common medications, and you can refer back to this note. Let's just make this more clear. You can refer back to this note and just look at the medication that can cause that. And it's important to know their class of medication and what they're intended for. So for major depression, for schizophrenia, for insomnia, anxiety, and that sort. So they are these 4: insomnia, anxiety, depression, schizophrenia. So that's the call from the psychiatrist. Okay, scenario 2, the infected patient on antibiotics. The patient may be an infective endocarditis patient, so that's ours, that's a cardiac patient. Review patient's drugs for any of the following that would cause QT prolongation. The antibacterials, erythromycin, pneumonia, for example. Moxiflox, it's used at a variety of things. It could still be a chest infection, could be something else. And levofloxacin, it could be things, genital tract infections. Levofloxacin, for example, is used with tuberculous patients. That's something that we see commonly in our region. Antifungals, voriconazole is very important, and it also has a lot of enzymatic activity along with erythromycin. These two are really important to know in terms of complications and interactions with cytochrome P450. Antiviral, we're looking at foscarnet, that's foscavir, for CMV and herpes viride. We get this question in the context of cardiac transplant patients. So these patients are at a high risk of developing CMV virus because of their lost immunity. Remember, transplant patients, we're usually going to put them on calcineurin inhibitors and antimetabolites and that sort of thing, and as well as high doses of steroids immediately after transplant, and then with any relapse or with any acute myocarditis or myocarditis due to rejection. So whether humoral or cellular mediated, we can use steroids. And that's something different from post-transplant vasculitis, but that's something that we'll discuss in a separate note. So this is something that's also very important to us as cardiologists, that we actually do have our own patients who are post-transplant under our care, and they'll come with CMV, and they may prescribe foscarnet, and then they can develop prolonged QT. So the question is, are they on any other cardiac medications or not? Or maybe they're with a really healthy graft and the transplanted heart is great and they're not on any antiarrhythmics. Then it'll be your clinical judgment to just monitor. But if there are interactions, there are any medication that prolongs QT, class 3 especially, you want to be careful. A question that'll come on the boards is also asking about HIV medications. Again, this is very high yield. Recall that HIV in cardiac patients can affect and cause pericardial disease, HIV, cardiomyopathy, HIV pericarditis also, and pericardial effusion, as well as pulmonary hypertension. And that's pulmonary hypertension is not related to the CD4 count. At a separate note, I'll discuss with you the prognosticators, because each one of these presentations, some of them have good and some of them have bad prognosis in terms of HIV and the heart. Let's take scenario 3, the consult from the neurologist in this case. You want to review a patient's drugs for any of the following that would cause QT. So the idea is the moment you get a consult from ID, you already know, and if it's about the ECG or QT, you already know which medication you're going to look for. Even if the infectious disease or the psychiatrist or the neurology physician do ask you about something else, they're not specifically asking about these medications, it is prudent that you look for them. So in the case of the neurologist, you want to look for fosphenytoin and phenytoin. Remember, phenytoin is actually a class 1B antiarrhythmic. It's just we don't use it all that much for antiarrhythmia, but it is a class 1B according to the von Willebrand classification. It has little effect on QT. Fosphenytoin is also a QT prolonger. And so you want to look for, once they combine with other QT prolonging medication, it's a problem. Scenario 4, it's a problem, but you don't have to necessarily stop it. You just need to monitor and see if it continues to prolong, if there's any proarrhythmic effect. And then there are cutoffs after which I don't feel comfortable to leave the patients. Like once the QTC reaches 500, to me that even if they're asymptomatic and they've never manifested anything, I can't send them home alone on that. I just don't feel comfortable above 500. But the cutoffs for what is normal, as we've discussed in the previous section or the previous video, has a definition, although if you go back to literature, these definitions are somewhat arguable. So scenario 4, consult from the oncology, palliative care, or even general internal medicine, this time for nausea and vomiting. So any patient with nausea and vomiting, review the patient's drugs for any of the following that would cause QT prolongation. Droperidol, anti-dopaminergic drug used in antiemetic or antipsychotic, and octreotide, which is used as a vasoactive for vasoactive symptoms, including carcinoid tumor. Remember, we see carcinoid patients for the tricuspid diseases because carcinoid tumors, if they're vasoactive, then the serotonin derivatives will actually cause fibrosis and neomembrane development and tethering of the tricuspid valve, and it can involve other structures in the heart. And so think of carcinoid tumors' effects on tricuspid valve as well. So these are all things that are important. So patient on octreotide, you get a consult, and they might ask you because the patient has heart failure, and you do your echo and you think of proarrhythmic effects, and you be careful when you prescribe a class 3 or a 1A medication or a drug that would otherwise prolong the QT. So let's take a few more drug notes before we conclude this section. Mexiletine is a class 2B medication, the oral form of lidocaine. With those with structural heart disease, this is a good drug as an add-on for patients, structural heart disease patients. We don't use mexiletine alone. Usually we add it to class 3, so it's amiodarone with mexiletine, sotalol with mexiletine. One question that you'll be asked about potentially in exams is those with structural heart disease and VT, which medication you'll use. So it'll be sotalol for the patients with preserved ejection fraction, amiodarone with low or even preserved, but if they're low, sotalol gets out of the picture. Of course, the question might only give you sotalol, then okay, you can choose sotalol if you don't have the amiodarone option, but if you have amiodarone, sotalol would automatically be wrong. Also remember, for choices on the boards, they're asking you for what is the most important choice or the most accurate choice. You can easily have 2 or 3 choices that are correct, but they're looking to see your clinical judgment skills and whether you can stratify and triage and decide what is safe and what is not. To summarize all the cases above in terms of QTC prolongation as an adverse effect of the drug, the drugs are here. You can pause this and refer to it at any time. For pregnancy, sotalol and flecainide appear safe in pregnancy. Amiodarone neonatal goiter can occur. but you do use it if needed. For calcium channel blockers, let's do that. For calcium channel blockers, only verapamil and nifedipine. Diltiazem is not studied, but we don't like to use it because we have alternatives. We have nifedipine as a dihydropyridine and verapamil as a non-dihydropyridine calcium channel blocker. For the beta blockers, you cannot use atenolol. Just don't use it in pregnancy, right? We know that our reflex is to use beta blockers in pregnancy because since medical school, we're told if a pregnant patient gets hypertension or preeclampsia or that, use labetalol. But it's not a class effect. In fact, most of the treatments of beta blockers where you derive benefit, it's not a class effect. It's an individual beta blocker that works well with hookem, an individual beta blocker that works well, or a group of selective beta blockers, and not all selectives, mind you, that actually work well and have a mortality benefit in the heart failures, and then specific beta blockers. Labetalol, namely, is the safest one in pregnancy, but that one is non-selective and it's good for hypertension. For the heart failure patients, carvedilol may be bad. There's no data. Metoprolol, these are the selectives. Metoprolol can be used, but you want to monitor the patient under all circumstances. Labetalol is the one that is most commonly used. So metoprolol, labetalol, okay. Carvedilol, maybe, but shy away from it. Along with diltiazem, you want to shy away from those. But do not, and this is what you would be asked about. Do not give atenolol amongst the beta blockers in a pregnant lady. Beta blockers are preferred over calcium channel blockers in general for rhythm control in the pregnant patient. Further note that further discussion about the other causes or other classes of drugs in pregnancy are found in the pregnancy section, and we will discuss that briefly in the white notes in the hypertension section as well. So risk factors for digoxin toxicity, this is the last thing we'll discuss today. Impaired kidney function, older age, and female sex. Here's an important caveat that will also appear on the boards. When asked for a patient on digoxin and they're developing VF and they need recurrent shocks, and you want to do a lab to make sure that if you deliver shocks, then the shock will be effective. The most important lab is potassium, not digoxin level. Digoxin level is also influenced by potassium, and therefore potassium would be the most important thing. And because even during resuscitation, we were looking for reversible causes, you can do that quickly while doing CPR on a patient who has VF, for example, and you're delivering shocks, they're not coming back, and you're going for your next cycle, so you have at least 2 minutes now. You can do a quick panel on the VBG-ABG machine and actually get a potassium result. Hopefully it'll be a good draw. It shouldn't be a traumatic draw because that'll increase the potassium levels factitiously. Organs affected by amiodarone toxicity. So just remember these four organs as organs you can't forget. Liver, so you can get really bad liver dysfunction, and you can get fulminant hepatitis and liver failure in someone who had arrhythmia and hypoperfusion of the liver, especially if someone had an MI, for example, they're in the ICU or the CCU, so you already have a potential for liver dysfunction. Your first day, the patient is hypotensive and going into shock, but the liver panel is normal, and they develop some sustained VTs, and maybe you even needed to shock them back, but there was no full CPR. They were shocked. They come back. You want to put them on amiodarone to prevent this from happening while they are your client in the CCU. In that case, you want to be careful to really understand that between the hypoperfusive insult that's happening day one, maybe the labs are still not abnormal, the liver may be ischemic, and you add amiodarone on top of that. I have seen patients with ALTs and ASTs in the 2,000 and 3,000s in that specific scenario. Lung fibrosis, thyroid hyper and hypo, and of course, eye side effects and color vision.